In the spring of 2026, the American College of Cardiology and the American Heart Association published their new 2026 guidelines for managing dyslipidemia, or cholesterol issues. These were an upgrade from the 2018 guidelines that had been followed up to this point. And there were three major changes made to these guidelines in 2026 that you need to know about because it drastically impacts proper cardiology, or how cardiovascular disease should be followed. So number one, the first thing that the guidelines said is that the pooled cohort equations that cardiology has used for the last decade to determine your cardiovascular risk have been overestimating risk 40 to 50%. Say wow. They've been overestimating risk by 40 to 50%, which means many people were told they were at risk that were not, and maybe put on medications that didn't need them. Interesting. The second thing, they said that there is now class 1 evidence in their opinion that the marker lipoprotein a should be run on every adult in America at least once. Lipoprotein a is a cholesterol marker that shows you the genetic contribution to your cholesterol levels. Because we can't change your genes, you only have to run it once in your lifetime to understand, does genetics explain your high cholesterol? If it does, that helps us understand, well, we probably have to adjust what your normal cholesterol level will be, or what a realistic target to get your cholesterol down to, if that in fact is a worthy clinical goal in your case, should be. So genetic contribution to your cholesterol level. Everyone should have that at least once in their life. And then third, they state that the marker apolipoprotein B, or ApoB, should be used to follow cardiovascular cases. So this is the marker. Other publications by the American Medical Association and the American Heart Association have been quoted as they believe that ApoB should be the primary clinical focus and of management in atherosclerotic patients. So throw out total cholesterol and LDL. They've been shown many times to be not worth the money to follow cardiovascular risk, and I dive into this in my forthcoming book on cardiometabolic disease very deeply. But they say ApoB is what we should be using to manage cardiovascular cases and identify cardiovascular risk. And it's even great to use in cardiovascular disease patients, like secondary prevention patients, diabetics, chronic kidney disease, obesity, and any hypertriglyceridemia issue. So those are the three major new upgrades from the 2026 guidelines that were published in the spring. Well, this week in July 2026, multiple papers have been published in the Journal of the American Medical Association that looked at CDC data from the NHANES survey to see where do Americans fall with the new LDL and cholesterol guidelines that came out from 2026 guidelines. And what they found is that 87.5 million Americans aged 30 to 79 without heart disease now qualify for statins, but they're not on treatment. Okay, so with the lower LDL goals set by the new guidelines, there's now 87.5 million people who, based on those guidelines, should be on statins who are not. So they're saying this is a huge care gap, we have to fix this. But if we've just agreed that LDL and total cholesterol are not a good metric to predict cardiovascular risk, why are we going to say this is a big problem? Shouldn't we funnel those people through this rubric first and say, hey, do they have high cholesterol because of genetics? Or hey, is their ApoB fine, but their total cholesterol and LDL are high or not at goal? And in that case, it doesn't matter if their ApoB is fine. So there's other markers that are better indicators of cardiovascular risk than total cholesterol and LDL. So that's a question I have for them. Why are we still focusing on that when those markers have been shown to not be as useful as other markers, which you say have class 1 evidence to use? But anyway, so of those 87.5 million people that they claim need to be on statins or need to be on treatment, 22 million of them are people that didn't qualify for treatment in the 2018 guidelines that now do by the 2026 guidelines. So there's 22 million more market share is one way you could look at that. Okay, most of those 22 million people who now fit their rubric for treatment under the new guidelines are young and low risk. So they would fall under what's called primary prevention, which means they have no history of cardiovascular disease. But this is where prevention really shines, right? You take action before the disease develops. So the author said, you know, this should start the conversation of prevention and taking action, not necessarily lead directly to a statin pill. And what I think should happen, and what the authors say, is that lifestyle needs to be considered. And so should we take these 22 million people and give them statin drugs just because a new guideline was published? No. If we're concerned, we should discuss lifestyle and clean that up. And also, don't go by the LDL and total cholesterol, feed them through this rubric, and then we could narrow that 22 million down to, well, who fails this? And if they fail, now we're more concerned about those people, and still lifestyle first, and then medication down the road if necessary. So that's very important. The authors say, quote, "This is a huge public health burden for a condition that is highly treatable, and it's a missed opportunity by the healthcare system." Well, yeah, I've been saying for a decade plus that the healthcare system is missing the opportunity with cardiovascular disease. They've been using statins for 39 years, yet heart disease is still the #1 killer. It's clearly not lowering cholesterol that's going to solve this puzzle. It's lifestyle, it's nutrition, physical activity, stress, sleep, exposome, environmental factors, toxins. Okay, that's what we need to look at. And so that opportunity is, yes, 1/3 of adults that are 1/3 of the new group are primary prevention adults, and most of those are younger and at low risk. 76% of those are not on any treatment, nor should they be, before we take them through what the evidence is saying should be done first. And again, if they fail this, let's address lifestyle. What about secondary prevention patients that aren't at goal? Secondary prevention patients are people who have had a heart attack or a stroke and now are on medication to prevent a second one. Well, the paper said for secondary prevention patients who aren't at goal, even though they're on medications, they need more intense medications. Well, if that means more statins, that's not necessarily going to yield better results, because research suggests that after the first dose of statin, increasing or doubling dose only yields a 6% more benefit. So you get almost no more benefit for doubling the dose, yet the side effect profile doesn't decrease at all. So if those people are on medication and still not at goal, still have residual risk, have these been tested on them? Has their blood sugar been checked? Has their lifestyle been checked? Here's where lifestyle can really shine. Let's go back, and the opportunity for the healthcare system would be, well, let's go back to what you missed. You didn't look at them as a whole person. You didn't assess blood sugar and sleep and stress levels, etc. So maybe those secondary prevention patients will improve if you go back and look at them as a whole person and look at their life as a whole puzzle. So I want you to be aware of the 2026 guidelines, the major upgrades they made, so that you can take this information and go ask your GP or your cardiologist, hey, I've never had a lipoprotein a. Will you run it on me? I'm interested in knowing my genetic risk, or how much my genetics are contributing to my cholesterol level. Hey, I've never had an ApoB run on me. The American Heart Association and the American Medical Association say this should be the marker we're running to follow cardiovascular risk. Will you please run it on me? And if it's high, you can take action. Discuss with them lifestyle strategies that will reduce this. Take those, retest, is it working? That's how cardiovascular disease should be assessed and dealt with.